Okay, good morning. This is Sandy Abrams. Thank you for joining us. I just want to make sure that you have your handouts. I've sent you a total of 4 distinctly different handouts. One is the body of rules that we work through for OPI. Another one is a PowerPoint presentation that we'll be going through today. And then we have the last 2 I sent out this morning, and they also are showing over in your handout section, which is the pop-up that you're getting as you are here in the webinar. And that deals with OPI referrals and intakes, and then the rules that relate to that. I just would love to have this be pretty interactive, but because we're going to record this so it can last hopefully for a year or 2 and be helpful for other new directors and new management staff, please text or put into the questions section your questions, and we'll do our best to respond to questions as they're coming in, and as well as I'll do an FAQ if that appears to be what we need. So we're going to launch off with those thoughts. If you could please chat or question me if you have any problems hearing us or seeing the slides. I want to start by introducing Sarah Odell, who's going to give us a welcome today.
Good morning. As Sandy said, this is Sarah. I'm the manager for the State Unit on Aging, and I just wanted to give a special welcome and thank you for attending today's seminar or webinar with Sandy Abrams, who we identify within the State Unit on Aging as the Oregon Project Independence Guru. Her depth of knowledge and expertise in this area is immense, and we're grateful to have Sandy on board with our team, and happy to say we will get to continue to have her working with us into the new biennium. I just want to give a special welcome to some of our newest directors, Mira in Washington County, Laura with RV-COG, and Caroline with Mid-Columbia, as well as the rest of you who are probably very familiar with Oregon Project Independence. So this is really just the beginning of some webinars and trainings that Sandy will be providing for you all. I know you will learn a lot from Sandy. Her passion will shine through as she shares her knowledge of this program, and desire that we have the best for Oregonians who have the opportunity to participate in Oregon Project Independence, which is a long-standing, very successful program. So we're hoping you have a good day with her, and I'll turn it back over to Sandy.
Thank you, Sarah. What kind words, and I appreciate your support. So let's learn this morning more about OPI. As I shared with you in the oversight of this training, I want this to really capture many of the areas that you as directors and managers will need to be aware of so that you can better manage and problem solve issues that come forward. First off, some history. I always think that's important for us to get to know as we are aware of and present about this program. The program was actually started and initiated in 1975, so it must have been somebody's brainchild prior to that, right? That's how it works. But in 75, look at this list of information. What a year it was. I mean, everything from President Ford being our president, Governor Straub, our life expectancy was 72.6. Today, 79.1. Song of the Year, Love Will Keep Us Together. Who can't forget Captain and Tennille if you're of my age group here in our 50s and a little plus. The patent was given for the first mobile phone. What would we do without them? Here we are today in a room filled with phones and other wireless equipment. And that was when OPI was conceived at the legislative level, and it was conceived by the advocates. The advocates brought it forward into a House bill, and the House bill was then moved to a point where it created a call out for the division, the Department of Human Services, to take a look at this And the need really was to point out that there was going to be a gap, that all of our services at that point in 1976, 75, were being focused upon the Medicaid eligible. And there were a whole lot of citizens who needed just a modicum of assistance, just a handful of help, and wondering where they were going to get this help. So we noticed these folks falling through the cracks, and also to be remembering that at that point we weren't having the variety of long-term care choices folks have today. We had foster homes, but they weren't certainly not licensed in the same way they are today or monitored. We didn't really have assisted living. They were just baking ground and beginning to come into the area of concept up in certain areas throughout the state. And it was an important time to really look at in-home care as an alternative to nursing facility care. So we really kicked off in '76 with a $1 million budget and plunged into this concept of how can we better serve the people. In 1981, the Senior Services Division was established here within the Department of Human Services. Today we call it Aging and People with Disabilities. We saw other services move into the area. We saw adult daycare become as a licensed, paid-for process. We saw respite care get added into the OPI rule, as well as personal care. 1987 is when we opened it up specifically for individuals who had Alzheimer's or a related disorder. But at that point, we set it up so it was in a separate designated fund, and it wasn't being used. And so it was later in '91 when it was opened up and included in OPI, if you will, so that people who are identified in that age range of below 60 could have access to it through our traditional, if you will, OPI program. So it allowed for that variance of age of the consumer who had that particular issue with Alzheimer's or other related dementias. In 2002, we began to see some major budgetary issues occur here in the state. And not only did they occur over on the Medicaid side, but for us in OPI, they significantly impacted us. OPI was closed by the division, meaning no new intakes. You can only maintain what you currently have. But then we were reopened 7 weeks later. We have wonderful advocates who have supported our program from the inception, and that, as well as the season of the time, seeing that even just a modicum of services will help keep people out of long-term care. In 2005, we had our rules updated and expanded, and at that point was our first cast into wanting to serve folks with physical disabilities who are the age 19 to 59. And related to that, they created a special OPI fund. However, in that statement, it prohibited the expansion until the amount of monies for OPI was sufficient. That in and of itself pretty much stopped us from being able to serve in '05 and beyond, because there wasn't enough money accumulating in this fund of dollars. So we didn't see opening up for our younger population into the pilot expansion until 2015. Once again, in 2010, OPI was eliminated. We were told in June that the program would be closing August 1st. And I know as an OPI worker from that point, calling around to every consumer, making home visits, explaining options, helping people through that, it was agonizing and horrible. I would hope that at least in my career we never have to go through that again, but we also know that we have to live within our budget constraints. What did occur out of that was from the cry of our consumers, the advocates, their families, reaching out to their legislators, was the ability to find enough money to maintain the OPI program with new enrollment being frozen. And that was until August of 2011. It was reopened, and then it was closed again in January of 12. So see, when I look here at this segment of time, we were open, we were closed, we were frozen, we weren't. And I think when we begin to talk numbers, and many of you are having these conversations right now with your advocates, with your legislators, and they ask about what's the growth been, we also have to so importantly remember that this blanket lays on top of it. And to be aware of those things. Finally, here in July of 2013, our rules were updated. And then in 2014, we started to develop the guidelines. We had the 7 AAAs who were going to run the pilot expansion. And in 15, the expansion really took off. So just numbers. I mentioned them earlier, so let me hone in on that for you. We had our largest enrollment in June of 2015, 5,251 individuals. I say Yahoo. That are people who did not have to turn to the Medicaid program, who were just getting this modest amount of in-home hours to help flourish in their own home, which who doesn't want to live in their own home as long as they possibly can. Today, the end of January, had to think through how I gather those numbers. We have combined of the pilot program and of our, if you will, traditional OPI program, 2,089 individuals. 1,789 of those are in our aged program or traditional program, and 300 in our pilot. Through all of this, our goals have really remained the same. Promote a quality of life and independent living for adults and people with physical disabilities. That's pretty easy for all of us who are in human services and have a heart for the aged and the physically disabled not to be able to stand behind. We want to be there and do that. OPI is to provide preventative long-term care services for folks to reduce the risk of institutionalization and promote self-determination. You know, that word institutionalization, doesn't it grab our attention? Because we all probably have a similar reaction of somewhat of a dislike to that. Yet, realistically, when you go into one big building or a connection of buildings that have staff changing and you're assigned a certain part of a room or a room, that is exactly what it is. And I think that many of those that we serve still view these buildings of care, these situations outside of their home, as an institution. And I tend to try to believe in the concept of name it as it is, and it is that sense of being in an institution. So we're trying to really work with folks to prevent them from going into those settings, as well as to help them be more self-determined. We want to provide services to the frail, to the vulnerable, to adults who are lacking or have limited access to other services. So we can go ahead and link arms, if you will, with other Older American Act programs, Family Caregiver Program, options counseling, home delivered meals, to name just a few. But we also link arms with Medicaid programs. We have the SNAP program, so important for our low-income seniors and people with disabilities, that helps them stretch the money and have better nutritional opportunities, if you will, as well as into the Medicare savings plans. And we'll look further at how we can join arms with Medicaid in a moment. As well as we really want to optimize their personal and natural supports. Those community connections. You know, I don't care what program we are, whether we are in a home health program or we're in an OPI program, we're an artificial support. People have their own connections that are unique and individual to them, and we want to help optimize those. We never want to supplant them. We never want to step in underneath and pull it up and see if folks can do better with ours. So I think it's better to help their programs, their people, if you will, gather around and give them that support. We want to check in and see if we have any questions. I'm not seeing any getting typed in. I want to encourage you again that if you have questions throughout this, please go ahead and type them in, and we'll fit them in as best we can, or I'll do an FAQ. I want to look at how Oregon Project Independence is defined in the Area Agency of Aging within the rules. So our first step into some of these screens here, I'm going to be looking at the rule and what does it tell us, because ultimately that's what we're all held accountable to as either the State Unit on Aging or an Area Agency on Aging. The Area Agency on Aging gets to choose the type and the amount of services that are going to be offered in the OPI program. That's not up to the State Unit on Aging. It's not up to the liaison. It's up to you. It's up to your field. It's up to your advisory council. What would be best to serve your folks? You're able to state what service types and how many hours they're going to have of those service types. Again, it's in the OPI rules, we do not reflect over to the Medicaid rules regarding in-home hours that are suggested in our client assessment and planning system, our caps. We are able to state what are our caps within our own AAA. We also have the ability in the AAA to decide which providers will be serving our consumers in our district, in our area, and how they're going to be monitored and evaluated for their performance in meeting the needs of these individuals. You're able to identify who's going to be served. Many folks use the service priority level as the key, so that level 1 through 18, and that comes out of an algorithm that is kept within Oregon Access. And in Oregon Access, there's a sub-program called the Client Assessment and Planning System. That's the long name for CAPS. You'll see it often, and I've referred to it here in the presentation as the CAPS 2 because it is the second versioning of that. It has been in existence since about 2001 or so, and through all of the ages, if you will, we are able to see through this algorithm a service priority level. And many AAAs choose to serve 1 through 18. Some may choose to serve because of economic situations with their OPI program 1 through 13. Some are serving 1 through 15 or 16. It is up to you, and it's looking at what is that impact? And I'm going to show you that we provide you monthly tools to be able to look at that and do an overview for your own management of your program. So another area is you want to know that you're able to see how are your staff going to do an intake and ongoing screenings, because you want to make sure this consumer is able to stay connected with other situations that may arise in their life. We're never stationary. It seems we're forever changing. So we want to be able to connect them into, maybe it's another OAA program, maybe it's a program that's going to bring in some low-income energy assistance, or maybe it's going to be a program that would link them into a support group for dementia. Any which way, we want to make sure that our case managers, our service coordinators, which is, I'm going to use both names, both terms, meaning the same, because in our 2013 rule, we got rid of case management and we brought in service coordination, and many of us call that individual in our agency still a case manager. We may call them a service coordinator. So if you have a bent one way or the other, please forgive, but that term is what I'm meaning, an individual who you have put on your staff to do these assessments, to maintain that connection with the consumer and to assist them. You're able to determine the cost of the OPI service. So in your contracts, you're able to see that. Some AAAs give an indicator to their staff of how much monthly per consumer they're able to spend, and have the service coordinator work within that monthly budget. Others say it's a maximum of X number of hours, whether it's provided by an in-home agency or by a home care worker, or any of your other services that you may fold in that are available through OPI. You also create how your fees are going to be billed, collected, and used. So, we talk about OPI. Remember, OPI is also a means for you to collect dollars from your consumers. It's not a free service. Even though an individual may be have a sliding fee scale, and we'll look more at what does that mean, you can gain income back to expand your OPI program through OPI by the sliding fee scale. You also are able to set up your own non-payment policy. Many of you have all of these policies and procedures. We just went through an area plan approval process and submission process here in the late 2016, and all of that was included. And if you want help to review that, you want some hints on how to maybe make your policies and procedures more user-friendly for your service coordinators, case managers, let me know. I'd be happy to walk alongside of you and help you work through that. In your area plan, you also have a policy for individuals, helping them understand what their right to grieve is. So, excuse me, in the Medicaid world, which often the OPI program is compared to, we have the ability for an individual to put forward a complaint, to put forward a statement saying, I have been unfairly judged or treated. And those have specific guidelines on how those are going to be dealt with. Now, these are not hearings that we have in the land of OPI. We don't get federal dollars, so we don't have to follow those guidelines that the APD offices have to follow. Or if you're in a Type B, that you have to follow with your Medicaid. Remember that this is really about helping this consumer understand that if they have a reduction, if they have anything that they may decide is adverse in the way that you are providing them OPI services or a complaint, you want to have a policy, a procedure that is clearly delineated for your staff to be able to follow. That way you aren't going to have to deal with inconsistencies, which is often one of the complaints I know I would often get is, why did worker X not do the same as worker Y, because my girlfriend got this and I got that and we're the same, and those take too much of your time. You need to focus on the bigger stuff. So putting good policies in place that your staff can enforce and have means of communicating. Lastly, in the area plan, you see that it creates that policy for denials and termination and reductions. I don't have a crystal ball, and I'm not even sure that it would work during legislative session. And wouldn't we all like to know what's going to be in the future of OPI? I sure would, and I'm certain all of you would. So let us just be aware that we want to have all of these thoughts kind of in process. I suspect in the near future we will be having some conversations about if OPI does transition down to what was in the governor's budget, that $5 million, how are we going to move to that from our existing population? And conversations will be beginning, but keep your eyes open for things regarding that. I see a question, and I'm just going to open it up so I can read it. Thank you for the question. It's saying, can you reiterate the flexibility options to manage the existing clients again? I sure can. The key here is to look at what you're coming up with as a monthly amount of money that you can expend for your OPI. And then based upon that, how many hours of service. And then you can do a change of policy and work with your staff to move towards that end, whether that is a 10% reduction across the board here in the month of April, or whether it's from March 1 forward, all hours will need to be at or below 15 hours a month. You are able to exercise that kind of very tight control of the OPI program locally. I would strongly encourage you to keep your liaison for the SUA in the loop on this, because they can be a great resource. As always, I would offer myself up anytime you want to discuss and kind of float out some policy ideas, and we can double check that everything is kosher by rule. And then also you have to look at your own policies and procedures that are guiding you, and what do you need to update to take the actions that you're seeing necessary. Let me know if that answers your question. Thank you for that question. Advisory councils. They're fundamental to our program. You know, in rule, it does state that our AAAs must have one. And specifically in the world of OPI, this is to confirm that we have representation from the communities that you serve in your area agency, and that you're getting that encompassing information also from your low-income individuals. Your minority individuals are represented there on your advisory council. If you're in a type B, you're going to have 2 different advisory councils, sometimes maybe meeting together, but they're going to be distinct, and that is for the disabled population as well as the aged population. They're going to help you in identifying what are the needs. That's really key. They're going to help you as you bring forward concepts and ideas on how do we manage this. They are going to give you what the term actually means, advice, and help bring you into that. Often, as all of us know as leaders, it's how you present the information, right? And so it's really key to be giving them the highlights of the program. Some of you who are new don't know what information they may have. And if you need some basic OPI material to discuss the OPI program to educate your advisory council, let us know here at the State Unit on Aging. We are happy to do that for any of the programs that we have. The advisory council is critical to you in helping you select the services you're going to be spending your allocated budget on. You're going to be able to look at the evaluation, the effectiveness of those programs, and then what more can you expand on and what more can you be doing. Know too that you have to meet at least quarterly. Doesn't mean you have to meet monthly, but it's excellent to keep good communication going and up. The next piece of OPI, now that we have a program and an area agency on aging and an advisory council, is going to be dealing with your contract. These are, pieces of legal paper that are exchanged between the Department of Human Services and your area agency on aging, whatever you are, whether you're a council of governments, a county, or a freestanding program. There is an interaction there. In that, it talks about your area plan. And in your area plan, how you are following that and being guided by that. It talks about reporting requirements, that infamous 148-150. I don't care whether you've been there 6 weeks or 6 years, that those forms that are sent back over here to the State Unit on Aging, which result back into the funding and shows the use, are critical. Not saying they're the best, but they're critical. And we are certainly learning as we have gone through staff changes here at the SUA. We're learning and we're growing, and you're going to have more information coming on those very pieces that relate back to OPI. If you have ideas or thoughts about that, please feel free to be sharing them with Sarah and giving us concepts. The data reporting. Let me say that again. The data reporting. In as critical as Oregon Project Independence, which is the theme of this conversation, is, it is vital for us to see that in Oregon Access, which is our primary piece of reporting on our consumers, is up to date. Linked into that then are the NAPAS information that's held within Oregon Access. And out of that, it draws the RAIN reports. These reports are downloaded every night and loaded up to the federal government, reviewed over, as you all know, quarterly as well as annually, and working through that. And recently, you've been hearing a lot from the State Unit on Aging on how important the RTZ, the Get Care documents are in the ADRC database. All of these pieces help authenticate the work your team is doing so that funding has reasoning, and that's critical. By the contract, it states that you need to have information systems. There's some language in the contract that deals with landlines and computer technology that is required, and various pieces of information regarding that. In the contract, it does specifically say that you're able to request funds for services other than those listed in the rule. And we'll be looking at what services OPI has in a couple of screens, but I just wanted to make sure that you're aware that you're able to ask for a variance on that. It has to be pretty well thought out, but it's available to you. Within your program, you need to show that you're doing program monitoring, some oversight of this OPI program and how is it going. As well as in the contract, it does list through just some generalistic, is that a word, general, some agency general management pieces, that being your criminal history checks for both your staff as well as your volunteers, abuse checks on them, how your staff are mandatory reporters. Hopefully we will be having a further training on just that very subject within the next couple of months. How important it is for you to be ADA compliant with your facility. What is your grievance procedure, as well as your competitive procurement of services, and how you gain your contractors. Of course, you have to have personnel policies to make all of that happen, and it's just a reminder, because it's in our rule, that you have those, both for yourself as a AAA as well as those that you contract with to do the services, those agencies that you have. And if you're in non-compliance, things that could occur, there could be a result in a reduction or termination of OPI funding, or even if the amount is reduced, to know that that reduction due to non-compliance is done by the director. And whenever we use the term director, in the rule, it's going to refer back over to the Department of Human Services or its designee, which in our case would be the State Unit on Aging, back over to Sarah. So those services, finally, let's talk more about just OPI and stop talking at AAA, huh? We're there. OPI Services. Those that you can spend OPI funds for are home care, chore service, assistive technology devices, personal care, adult day services, registered nurse services, home delivered meals, and your service coordination or case management. Now, these are the basics. These are the fundamentals of what could help this individual stay in their own home and receiving services. So this is just being pulled directly out of rule. I've given you the reference here, but I want to highlight that it's in this that you're able to say, what is our mix going to look like in our district, in our AAA? Maybe you don't have an adult day service provider. Well, that wouldn't be offered then. Perhaps registered nurse services are too cost prohibitive, and so you have removed them and not using that. You encourage consumers on OPI who may need a registered nurse service to reach back to their physician to get home health or to go to a clinic to get those kinds of services. But you're going to look at this mix. Now, home care can be through the means of a home care worker, and it could be through the means of a home care agency. That's up to you again on which you want to offer and how you offer that. Now, as you're seeing on the other side of the screen here, there are other services that you're able to bring in. These other services are allowed on a case-by-case basis with approval by the director. Again, that would mean Sarah, the State Unit on Aging. These would be services that would help support community caregivers, strengthen that natural support, services that are evidence-based for the health promotion services, options counseling, or assisted transportation options. All four of those are specific to be only offered when you want to ask for an exception. Again, I want to encourage you to ask any questions that you may have. So who are these providers of care? I mentioned the home care worker. So currently, that would mean a person who's met those standards and requirements under a couple different bodies of rule, which would include that their criminal history check has been done, that they're free of accusations of substantiated abuse, and that definition of home care worker and the work around that is really work that the Home Care Commission does. We are in a very different, I think, situation with the home care workers because they are a union represented individual. They have a contract with the Department of Human Services, and our clients are their employers, but we are the employer of record. So consequently, we have to carry forward the agreements in this labor contract. And one of the key areas, directors and managers, I want to encourage your staff and for you to know of is that it's important that they use the registry system. Sometimes our home care workers do not promptly keep up their availability on the registry system, but that's their obligation. And it may complicate our consumers in finding. Nevertheless, we really need to use only the registry system. We really cannot have an office giving out their own list of OPI providers. If that is found, it is likely going to cause a grievance that we are going to lose, because it is very clear that we do not do that in the labor contract. Currently, a home care worker is being reimbursed, this started February 1, at 3 different levels of pay. $18.41 an hour is how much you are being charged for the basic home care worker. Now, their pay is $14.50 an hour. You're getting charged the $18.41 for the extras, the paid time off, their health leave, their coverage for workers' comp insurance, as well as mileage, by the way, directors, because you could have a home care worker who's getting service plan related mileage being paid to them, and it's not going to be reflected individually to your consumers or to you, because mileage is incorporated corporately to all of our consumers of OPI. It's included in this $18.41. The next step, up to $18.95, is the next piece, because now in this current labor contract, they gave individuals an ability for an extra 50 cents an hour add-on if they meet certain education criteria. And they were fairly substantial. Folks have to be CPR certified. They have to go through some ADL training, how to work with a difficult consumer, communication issues, professionalism. There's a whole series. They have to maintain their certification. If they've met all of that, then they're saying, we encourage it. It's like longevity, if you will, and they're giving this 50 cents an hour differential. Lastly, there is another group to get $1 additional, bringing the reimbursement rate to $19.49 an hour. And these are for home care workers who are working for an OPI client who has specific hands-on medically vulnerable care needs. And they, as the home care worker, have gone through the education and the training to meet those medically fragile needs that that individual has. They would get this $19.49 an hour reimbursement. So different than it was prior to January 1. But it is the way that we currently have this labor contract, so this is the way the reimbursement pieces work out. In-home care agencies, these are based upon your contract, AAAs, with the agency if you choose to have one. It's not running on the shirt tails of the Medicaid contract. It's a freestanding contract between your agency and that agency to provide services for your OPI folks. The rate of pay is determined by your contract with them, as well as the scope of services. And you probably have been alerted that there's a body of rules that's going to be changing how home care agencies become providers for Medicaid, that will be different than how it's been in the past. That will be coming out. There's been some preliminary pieces with it, and will be coming out within the next week or so. Any questions so far? So let's talk about money and data. What are allowable costs for OPI? Well, that would mean the direct services, those provisions of services that are done. So it's going to be how much was paid to the home care worker, to the agency for the assistive device technology piece, for home delivered meals, whatever it is that is a direct cost to them. Administrative costs are those expenses about the overall operation of the OPI program. And by rule, it states that those costs cannot exceed 10%. As you may know, at least you may observe on the 148-150, there is a line item on there that shows whether or not those costs that you've put in for administrative have passed that 10% apiece. So you just need to be aware of that. And so those overhead kind of things could be accounting services, it could be facility expenses, those sorts of things. Direct service costs does include your case management, your service coordination. So not just home care worker and agency kinds of things, but it also does include your staff time of the case manager, service coordinator. Data collection. Recently, I've had a series of questions about whether or not OPI consumers must give their Social Security number. Yes, they do. You'll find that in rule. The reason for this is that we create them in Oregon Access to be a unique individual. And if ever they convert to the Medicaid program, we must have it so we aren't creating duplicate people in this data system, this data bank. So a Social Security number is required. So am I saying that if they refuse, we can't serve? Ouch. That's really where the rubber meets the road, isn't it? I think that that's one of those delicate conversations with an individual to talk about safety and security of your records. When you put something into Oregon Access and you create a person in Oregon Access, there's multiple layers of security related to that. And I think however your staff communicates and carries forward those documents, being sensitive and aware of where the social number shows. We definitely have to have date of birth because age is an important aspect to our OPI program, and knowing what year the individual was born, as well as a unique identifier to them and their name. Another unique piece of data collection to Oregon Project Independence deals with that group that we serve who are under the age of 60, but in the traditional program, if you will, because of dementia. So if they have a dementia Alzheimer's diagnosis, we need to have that specific information directly from the physician and documented in Oregon Access. As I have trained your staff, I'm sharing that it needs to be over in the diagnosis section of the CAPS, of the assessment tool, because it's unique. And that is the criteria for getting this younger person onto this great program. So who qualifies for OPI? Who are these people that we serve, this 2,000 plus folks that we are currently serving today? There are people who've had the risk tool completed. This risk tool that we in OPI brought forward through the work of O4AD came in about 2012 or so. It could be, those of you in Clackamas, I'm thinking you might be able to help me remember if it's 2012, 2011, came forward with this information. In Oregon Access, we had a risk looking at what if the consumer doesn't have a caregiver? What risk do they have? What if they live in an area that is prone to certain natural disasters, tsunamis, forest fires, flooding? What if they live in an area that's known for gang violence and other kinds of unsavory activities that we'd want to be aware of? Those are risks. Those are captured within Oregon Access. But what isn't captured was this piece that we created for OPI, and that's a tool that measures the risk of out-of-home services, the need for getting care outside of their home. That is the front door to OPI. Critical. It is either a piece of paper that your staff can be doing and they keep in their consumer's record, or it can be put into the RTZ record. That's an either or. Each of your agencies have manners of doing it that works for your team. And if you want to explore more of how to use that more efficiently, please connect with me. You also, for folks who are getting OPI, you want to make sure that you have the capacity to add the consumer, that you have the budget to be able to serve them. So it's knowing where you are and how your budget is doing and communicating that out to those service coordinators so that they know whether they can take someone off the waiting list. When we rolled out with the concept of this risk tool, we also were very clear to say no longer are we looking at individuals as first come, first serve. We serve individuals on our waiting list according to the measurement of this tool of how needy are they for in-home services. When we do have someone who's on our waiting list, we want to make sure that we're offering them the services that we still have available, such as options counseling, a really critical program. Maybe you could get them linked up with some in-home private paid services, family care programming, all kinds of different things, ways of looking at the particular needs. Once we've made a decision that you can include them into your program, a face-to-face assessment needs to be done in their home setting. Now, maybe they live with their daughter and son-in-law. That's considered their home, and our assessment needs to take place in that setting. People cannot receive OPI if they reside in a licensed facility, such as a nursing facility, assisted living, residential care, or adult foster home. Now, they can live in a retirement center, a senior community, but they cannot live in one that is licensed because it would be redundant services being brought in. We need to confirm that this individual is not receiving Medicaid. So a search has to be done on the mainframe system as well as in Oregon Access to assure that this individual, with the data we know about them, their date of birth, social security number, the proper spelling of their name, that they are not already receiving a Medicaid program. In our rule, it's very specific that we do not offer to that population. And if they're under the age of 60 and have that Alzheimer's diagnosis, then we really want to be looking at specifically what is that diagnosis. And for the expansion program, that's when we serve the pilot expansion. We serve that age 19 to 59. And there are 7 AAAs in our state that are currently doing that. We want to help identify what these care needs are that would make this person have some unmet needs. That's done through the CAPS assessment. It's identifying what their activities of daily living are, what their supportive care needs might be. That assigns to them, according to that assessment, that is looking at their needs that particular day, what we believe their needs have been for the past 30 days based on our interview, and what we forecast their needs will be for the next 30 days. And that gives us the service priority level 1 through 18. You will also see in here that we have a service priority level 99, which means that they're independent. Now, it's very unique because in the Department of Aging and People with Disabilities, when we start using this language, independent to you and I could mean independent. The definition within this system with these services means that it doesn't meet the definition for assist or full assist. It doesn't meet the definition of assist or full assist. So yes, you need hands-on help, but it's only every 60 to 90 days. That's not going to qualify. Yes, you have fallen, but a fall does not constitute a care need in the area of mobility or ambulation. So just to know that independent has a different definition when we live in the land of OPI. We also want to be really looking at what are their needs, their unmet needs, as well as their family, friends, associates, that community around them that are helping meet their needs. We want to help support that. We don't want to take the place of that. Our program is mitigated to just a minimum number of hours. So it's really critical for us to be looking at what is the best use of the hours that we can bring into the situation. Maybe the son is doing fine at taking care of his mother, except for bathing. And so for that bath that mom needs twice a week, that's what we bring in OPI for, whether it's 8 hours a month or 10 hours a month, to assist with dressing and undressing and bathing and drying and all of those factors. We have to gather information regarding their financial situation. OPI is not a financially based program, but we have to know what is their current household income, and we need to know what their medical out-of-pocket expenses are. If it appears that this individual could be eligible for Medicaid, we should be making referrals to Medicaid. We should encourage them. It is not a criteria, though, to say you can't be on OPI because you are Medicaid eligible. I don't think we have yet had that right given to us to dictate to the citizens of Oregon what they can and can't do in that area. The coordinator, case manager, is going to help them sort through what is it that you want to have come. And so we want to really focus in on that very piece. It's what are you seeing? As I used in the example of the son and his mother and with the bathing assistance. We have a question. Household income does not include adult children who are not claimed as the dependents, correct? That is correct, and we'll be getting to that in a couple of slides, and if I don't answer your question then, would you bring it back up? I think it's in about 7 or 8 slides we'll be getting there. Great question, and thanks for asking. So the service determination really rests upon the AAA. That's directly out of rule. How empowering is that to you, managers and directors? That's saying that you all get to do that, but it's got to fit within the caveat of the rules. Sorry about that. Go back to the right slide. There we are. We have to be redetermining these, the need for our services on a regular basis. Certainly, I think we all think it's appropriate for staff who are going to be meeting with someone who's maybe had a surgical treatment of something and their recovery will take 3 to 6 months. We probably don't want to certify them for OPI services for 12 months. Because if in 3 to 6 months they have established themselves back to a baseline where they can be independent again, we want to complement that and withdraw our OPI services. And it's best use of our dollars. So working with that mentation for your team as you lead your team is going to be critical. To think about going back out and seeing people in periods of times less than 12 months. We are required by rule to see them at least every 12 months for a redetermination. We also need to update that information regarding their financial situation every time we go out and revisit with them. When we go out and determine their eligibility, makes sense, we want to make sure that that individual knows that they've been evaluated and what the outcome of that evaluation is. And so that's our service agreement. It has in rule that they'll get written notification. So there was a form created so that we are consistently the same across the state that is called the OPI Service Agreement. It is a form that is being kept in your case manager's files. It has in that particular form the number of hours, their hourly fee, what is the maximum amount that they could be charged per month as a consumer, what is the service rate that we're paying their particular provider, as well as the provider contract or contact information. Authorized services. This is where you're saying, once again, I'm just reiterating what I've already said to you, you get to pick and choose. If you say we're only going to meet the needs of individuals who are service priority level 1 through 13 and this person comes up as a 14, that means you're not going to serve them. You may want to offer them other programs, but you're not going to serve them with OPI. So it's just going back and bringing that up again. Whatever your local priority is, it can't conflict with the administrative rules or the ORS. You need to still be following under these rules that we have and that we have to work within. So remember, it's not a first come, first serve, that we're going to be maintaining the individuals who are already receiving authorized service as long as it indicates they have conditions, needs that indicate their services. And this is an important piece of our current rule. So you want to have that in mind when you're looking at reductions and how can we do what we can do within our budget. One of our challenges before us, men and women, is what I'm thinking. We also need to make sure that we're utilizing this tool, this risk tool that we have. So folks have the right to an appeal because they don't like the outcome of the situation. And so we spoke briefly of it earlier. You need to be clear about what is their right to appeal when they've been denied OPI services, what has been disallowed, maybe no longer will they get services from anyone but a home care worker. Whatever is this guideline, we need to make sure that they understand what their appeal rights are. Individuals are entitled to request this review, which would be an administrative review within your agency, however you have put that together. Again, bringing up the fact that this is not a fair hearing. It's not similar to those of Medicaid practices. But you want to give the consumer a right to communicate. Once you've gone through that process, then they receive the ability to continue their current OPI services until you have made a decision on this local grievance. So their services can continue during this time of initial protest, if you will, initial appeal. If, when you have made a decision and you have notified them in writing of that decision, if at that time they disagree, you are also informing them of the right for an administrative review by the department, which again in our case is the State Unit on Aging. And that you would be communicating that they would ask you for that, and you would forward that request to Sarah or to myself, and we would process that. During that period of time of an administrative review, the services are no longer being continued. Whatever has been the contested piece of the service change has now happened, and they are under a reduced or a closed service. At the time that the SUA would review this, we would go ahead and hear their concern. We'd review over what your findings were, and we would be giving a decision back to the consumer as well as to yourself about continued OPI services. And then just to keep in mind, by rule, we have that we are able to have all individuals, even those who've been previously terminated on OPI, they have the right to apply for authorized services at any time. So even though maybe they haven't paid their contribution for service, and you've closed them due to that, given them their fair rights for everything, or their appeal rights for that, they can still come back and knock on the door and ask for assistance. So now let's get to that money question, the sliding fee basis. OPI is rather unique because it's not just a gift from the state of Oregon, from your AAA. It is saying, consumer, you're eligible, you have a need for services, here's how much you're going to need to pay for these services. And it's wonderful that throughout our state, every AAA has the right and ability to set up how you're going to handle that. It's not based upon rules from APD. There is a one-time $25 fee that is applied to all new individuals receiving OPI who have their income is adjusted at or below the poverty level, the federal poverty level. So it's bringing it in. It's bringing it into that. You also have the flexibility to work with folks, like maybe they can't afford $25 this month. You could work with them if they want to pay $12.50 this month and $12.50 in May. That's up to you. There's nothing in rule that's going to say they can't do it. You can't have that. It's also making sure that they are aware they're only going to be billed for the services they actually use. They're not billed for what is in the service plan. Perhaps our service plan is for 15 hours, but they're only getting 10 hours. They're only going to be billed for the 10 hours they actually receive. So we're going to have to look at what is their household. And we define household differently than most programs. Wouldn't that surprise us? It's actually according to the IRS, and that's really a pretty simple one because all of us are acquainted with the IRS and have to deal with taxes. This is certainly the season to be thinking of that. But if we have a consumer of OPI who lives with her son and daughter-in-law and her family, their family, then it would be, here they are maybe in a family of 4, and this individual receiving OPI. Is that then a family of 5? Only if they're claiming that individual as a dependent. Again, it would only be if they're claiming the OPI recipient as a dependent. So it's really looking at who do they claim on their taxes. It's not who lives together. Very different from SNAP, food stamps, as well as from Medicaid. So if we have 2 siblings or friends living together, if they aren't claiming one another on their taxes, they're households of 1. If their husband is in a nursing home and our OPI consumer, the spouse, is living in her own home, they are a household of 2 because for tax purposes, they're still filing together. With that statement, we then gather all of the household's income as they choose to disclose it. We don't need to have it verified. Our Medicaid partners do. Again, it's as they choose to disclose. We have no rules that give teeth to, I have to see an award letter, I need to review over your statements. We don't have the ability to do that. So take it at their word. What is their salary, their income, their retirement, their dividends, pensions, annuities, rental income, whatever it is, We gather all of that. Then we also gather what are their medical expenses. And based upon those medical expenses, we're going to adjust their income to a chart, see it here on this page, that goes from 5% and then going up in 10% increments to 400% of the federal poverty level. How you choose to do your fee collection is up to you. Here is an important note for you, though. This is income to your program. So if you aren't billing, which you should be billing for everyone who should be billed, you're missing an opportunity to gain income that is being brought back to your AAA to expand your OPI program. That's money that you keep within your AAA. You never reflect it back to the state unit or back to APD. How we gather this information is on a form. Again, in 2013, we moved to create a form that is uniform throughout the state and created this 287K form, which is in all of your OPI files. It's a mandatory form, and your case managers ought to be doing that. And on that information, it will have their income. Unfortunately, this is not on Access. I hope for a day in the future that we can put this information on Access, because one of the critical components we're being asked as we put together information for the legislature and for oversight of the OPI program is what is the average income of individuals? What is the gamut? There had been at one point a perception that those who received OPI were rather wealthy. I think we now all know that these are not rather wealthy people. These are people who are trying to save and stay off from the Medicaid program. It's up to the AAA. Again, according to rule, you have to maintain a record of your fees, your surcharges, as well as contributions. And there's nothing in rule that doesn't allow you to not be receiving contributions from individuals on OPI. So I'm being asked to repeat the information about program income. Is it required that the program income be used for the AAA to support OPI services, or can it be used by other AAA services? According to rule, great question, thank you for asking. According to rule, it has to be turned back into OPI to maintain the OPI program. So let's say in a given year you get $5,000 of contribution and fees. You can turn that $5,000 back to OPI to expand your service. Let me know if you have further questions about that. Great question. So again, here's that fee schedule, and this is updated every year, usually about this time. We got it out middle of February with the federal poverty level. When it gets updated, we update this. I know that there are some AAAs in our state who reach out through OPI and ask for requests and other ways of adding dollars to the OPI program for folks who've received OPI services. I know that I have participated in situations where there has been a consumer who was very grateful to receive the OPI services and was actually paying 100% of the cost, which has brought money right back into the program to cover all of the expenses that are billable, and willing to make donations above and beyond it because they found it so valuable. What a great compliment to each and every one of you who have those opportunities. The one-time fee, that $25 that you collect, also is kept there as program income. We do currently have the expansion for the pilot of OPI for adults with disabilities. Again, this program was intended to see if we could move to a statewide program that is age neutral, to serve individuals 19 and older, period, who have a physical disability and basing it upon their functional needs. At this point in time, we do know that in the governor's budget, this program was not included. We also know that in our rule, this program ends June 30th. At this point in time, I am not being directed to take any actions regarding it. I have put forward some requests, and we'll be hearing more about what we are going to start looking at and doing for the pilot, but at this point in time, we're going on as business is the same for those 300 individuals receiving the service. I want to make sure that you're aware of some reports that could really help you function better as a manager, as a director. There's a couple of reports available to you in Oregon Access, specifically the caseload report. A caseload report is back in the report section, and some of you may not be very familiar with the Oregon Access, and I understand that, but you have staff surrounding you who are. And so you could have them help you through with all of those pieces. And I want you to take a look at this because you're going to be able to gather this information based with zip code perhaps, or program information, or by worker. And it's whether or not the worker is assigned to the case. It's not saying they are an active OPI. It's saying they're assigned to this particular electronic file. Their name is registered to it. And that's important because it will match up with a couple of the next reports, such as the CAPS 2 review report. This is a list of when their assessments of the OPI consumers is expiring. A CAPS is only valid for 12 months, and then a reassessment must be done. So this gives the case manager or service coordinator that list of who are they seeing. Again, it can be drawn by date, by zip code, or by worker. It's important for you to pull this up using all statuses. So circle that on your information. Circle this about all statuses. And that has to do with the fact that that status is drawn from Medicaid. So if they have previously applied for programs like Medicaid or SNAP and been denied, and you didn't choose the word denied, they're not going to show on your program, though they're approved for your program. The next group is some other key reports. The emergency concerns report. If your OPI team, your case managers, are using that risk tool within the CAPS. If so, you're going to get some great information for emergency planning. All of you just went through the exercise with the area plan of looking at emergency contingency plans. This would help you identify who's in that flood zone, who is in a tsunami zone, who's in a fire zone, different risks involved in that. What is the expectation by your board, by your advisory council, to oversight of these individuals during a disaster such as this? There's always some implications there. Take a look at this, see whether it would be fitting for you. If you want to discuss how you can get your team to use that more, let me know, and I'm happy to provide a training and some help with you to get there. Monthly, you're getting some SUA reports, and I just wanted to finally end up on bringing these up to you. You're getting a 148, 148B. These are sent out to you monthly. They are based upon the folks who are on OPI who have an approved service plan. So that would mean that if somebody has a late review, they're not going to show because they don't have an approved service plan. So you will see some variances, and when you try to figure out why is that, when you talk to your case managers, they're going to say, oh, I didn't get that approved until the 7th, but we backdated it to the 1st. That's fine, but we pull our report on the 1st, and if it's not sitting there as approved on the 1st, it doesn't count in our report. So there's always going to be that variance in this report to you. But it does come to you in Excel. And by coming to you in Excel, you're able to sort this information according to each of these various columns. And I really would encourage you to look at that. It includes service priority level. So maybe as we're talking about how can you reduce your budget, how do you know how many are in what area, you could sort this by this report, how many people you have in priority level 1 through 18. You're able to look at individuals by the number of hours, how many hours are on the service plan. That can help you for budgetary purposes too. You're also getting a report if you have people in your AAA. Okay, you don't get this one monthly. It's only when we see someone from your area agency on aging listed who is on the OPI roster statewide as well as on the Medicaid program. And we're sending you that report because as a AAA, you're taking the lead to work with that APD office to counsel and work with the consumer to make a choice of whether they want OPI or do they want Medicaid, because they can't have both. You're not able to do all the work of that. Your team can't. It has to be the APD office because of the insurance benefit that the individual would be losing, as well as to understand what could be their service benefit they could gain if they go for services under the Medicaid program. Both of these past two reports I've mentioned are done through the Office of Business Intelligence here at the Department of Human Services. They're reports that have just started to get out to the field since, June for the Medicaid OPI, and since September or so for the OPI listing. So they're relatively new tools that we're able to get developed and get out to you. I am interested in what other information you may need to help better manage your OPI program, and if you could send me any ideas on reports that you may need, please let me know. Finally, you get a monthly summary report from Brenda, who is our Office of Financial Services accountant. And Brenda sends this out to you or your representatives. Often it's your budgetary person, showing the total amount of whatever pay period has been deducted from your overall expense. So as you know, the Department of Human Services pays the home care worker service, and then they withdraw that from the payment to the AAA. And this goes into the specifics related to that. Lastly, here are just a few resources. There's many, many more resources available to you. And I just wanted to bring these up to give them to you so that you got them and you could maybe make them favorites with the Home Care Commission, where to get to the OPI rules, as well as to the SUA website. Okay, I'm going to minimize. I wanted to bring up this. I sent this out this morning as another handout because I created it really for you as directors. I gave it out as I went around the state earlier in 2016 after the OPI monitoring to talk about when do we count a case. And this goes through that whole series of actions. Your staff initially respond to a consumer call. That call may go into either the APD office or perhaps to your own staff directly, and they're asking for help from OPI. So then the first thing you're going to do is that risk tool, and they're going to look at your wait list. When you're able to open them, you're going to go ahead and you're going to send them out as having a face-to-face visit with the OPI service coordinator or case manager. They're going to determine at that point the service eligibility. They're going to complete the caps. At this point, you're able to build units for the case management services, for that service coordination, but you're not yet counting them as an OPI consumer. When they are ready to open the OPI case, meaning they're completely on Oregon Access, all of the forms have been completed, that's when you're able to add them to the unduplicated OPI count on the 148-150. I also sent the rules this morning out to you that are related to this, specifically pulling them out so you could look at that. I would never say that I am the expert at this. I want you to read them over and apply them to your situation, and let's have a conversation. Let's have a discussion. So those were the two handouts that I sent you this morning. Again, I don't see any new questions. We're right up to the hour that I wanted this to conclude. Feel free to email me directly any questions that we haven't gotten to, or any thoughts you're having after we conclude. I really appreciate you taking your time and getting an oversight, if you will, into the OPI program. This program is going to be being recorded, and we will have that translated and put onto our website. And I'm also going to ask Nicole at O4AD to put a link to our website so that it can join up there, so that you're able to hear this or direct other staff to listen in on it. And the handouts will also be posted there for you to look at. So thanks for your time today. Appreciate all of this great information and work that you do out and about in every corner of the state. I am here to serve you. And so let me know how I can be doing that. Take care and have a great day.